Thank you. So hi, everyone. My name's Raeesa. I am, like Jodie mentioned, a surgical pharmacist based at the Northern Care Alliance at Salford Royal. So this presentation is just to give you guys a little bit of understanding and just a brief introduction as to like what the role of the pharmacist is within the bariatric team. So just to give a little bit of a talk about what medications and the impact the medications will have post-surgery and what we can do. So first things first, so what happens to medicines once I take them? So if we have a look at this brief description of what the body does to the drugs. So when you take a medication, the first thing the medicines does is that it gets transported. It gets transported into the stomach where it can possibly absorb there, or it travels further down into the smaller intestine where it's absorbed there. Once it's absorbed, it gets distributed within our bloodstream, following which it is then either metabolized in various places within the body. An example is the liver. So when it's metabolized, that means it's either changes into its active drug or into an inactive drug, so it's no longer active, and it's then excreted. So the places where it's most commonly excreted is via the large intestine, by the feces, or excreted by the urine. So that just kind of gives you a brief example of what happens and what considerations we need to take when we think about what drugs we take. So where it's absorbed, where it's distributed, where it's metabolized, and where it's eliminated. So depending on which type of surgery that you have, so obviously one of the most common bariatric surgeries is the sleeve gastrectomy. So this picture on the right just kind of depicts what's left post the sleeve gastrectomy, what anatomy is left. So as you can see, you lose some of the absorption site of the stomach. So we need to think about drugs which are absorbed in the stomach, but you do still retain from this surgery a lot of your small intestine. The second most common bariatric surgery is the gastric bypass. So this is the Roux-en-Y type of gastric bypass procedure. So as you can see on the picture on the left, it depicts what's going to be remained. So you've got a new stomach pouch, and then you've got a connected part of the small intestine. So as you can see from this one, what remains is the stomach size and absorption is significantly reduced. So the only amount of mils that would be left in that stomach pouch is about 50 mils. And you've got quite a lot of the small intestine that it bypasses as well before it connects to the rest of the small intestine. So these are just things that we need to consider when we think about the medications that patients take. So what kind of effect will that have on the absorption? So with a sleeve gastrectomy, you're going to have a reduced gastric volume. You're going to have an increased pH because obviously the stomach is where a lot of the acid is produced. And if you reduce that, then that's going to have an impact and change some of that pH. You're going to have accelerated gastric emptying. So it's going to get through the body a bit more quicker, medications are, than previously. And with the gastric bypass, you're going to have all three of these things. So you're going to have, again, a reduced gastric volume, an increased gastric pH, and you're going to, again, have a shorter intestinal transit time. So again, the path that the medicines needs to take in order for it to be absorbed, and you're going to have a decreased surface area of absorption post-gastric bypass surgery. So will my body still be able to absorb medications? So it's not always easy, and there isn't always a black and white answer that yes, definitely will, or no, it definitely won't. It depends on the surgery and it depends on the medications. So that's where our job comes in and our role comes in. And quite often when patients come in, we will review all the medications, and post-surgery, we will have a look and make sure that these are all still suitable for you to take. Quite often, the effects can be measured in most cases, which is great. And so for example, if you're taking a tablet for your blood pressure, post-surgery, we'll still be able to measure your blood pressure, which is great, because then we'll still be able to know if the medication is effective. And that can be the case for a lot of medications. So for example, if you're taking medications for pain, if you're taking medications for heart rate, you'll be able to tell in your symptoms if this is still working. We also have lots of books and resources and experience on our side to help us work out exactly what you will absorb. Quite often we can figure out, again, by looking at the anatomy of what we're left with, by looking at the drugs individually, looking at exactly where they're absorbed, where they're distributed in the body, how you eliminate them, and we can have a very good idea of exactly whether you'll absorb it or not. And quite often it shouldn't be a problem for a lot of medications. And this absorption issue is, you can get what's called an acute period. So the acute period normally is just a couple of months after the surgery. And quite often, after years and years, your ability to absorb does improve over time. And a lot of the changes are just what we see in this acute period after the surgery. So what considerations need to be made? So I think, like I mentioned before, if we think about what surgery, what anatomy you guys will be left with post-bariatric surgery, one of the biggest thing is that the drug won't have as much of the intestinal transit that it needs to get through for it to be absorbed. So one of the things that we definitely do tell patients not to take anymore are modified release or XL preparations. So these modified release or XL preparations, what these medications are, is the way that they are made and manufactured pharmacokinetically, they are made that they are slowly absorbed throughout the body. So once you start taking them, they are disintegrated and you absorb them very slowly, and it releases its active components slowly throughout the body. So because of the post anatomy and the anatomy changes, and you're going to have less of a pathway to kind of get it through, we want to switch it to immediate release to give it less time for it to start changing to its active component. The other thing to consider is that the opening produced by, for example, the Roux-en-Y surgery, so the gastric bypass, is only 1.5 centimeters wide. So we need to consider the size of the tablets. So anything smaller than a 5p, you should be able to swallow whole. But anything bigger, we need to think about the impact that it will have on the surgical site. So if the tablet is larger than this, then we need to think about alternatives that we can give. So examples of alternative preparations are liquid formulation. So again, just thinking about it pharmaceutically, the reason why we don't like modified release tablets and why we may consider switching to a liquid formulation is that it's one less step for your body to undertake in order for it to be absorbed. So the tablets don't need to be disintegrated. They're already liquid formulation, and there's a chance that you will absorb it a bit better and quicker. The other thing that we might consider are soluble tablets. Again, soluble, as soon as you put it into your mouth, you're likely to start the absorption process from once it's in the mouth. We may even advocate for crushing or opening the capsules. Again, just making it easier, that one step easier to ensure that we get that absorption. And there are other routes of administration as well to consider, for example, patches. So liquid formulations are great, and quite often we do switch, but we do try and think about other formulations on alternative first. So we'll normally switch to liquid formulations in the 3 weeks following surgery. So again, what I mentioned about the acute period and how the highest risk is initially in the first couple of months after the surgery and of anything happening to the surgical site. And after 3 weeks, we can normally switch back to normal tablets. So the liquid formulations and thinking about these kind of medications and what you can swallow is quite often also to do with you probably won't have started your kind of normal oral intake by that point as well. We'll be on a liquid diet. And as you're slowly building up on your diet, we need to think about your tablets as well, because again, obviously some of the tablets can be quite big. The problem is with the liquid formulations, and that's something again that we need to consider, is the volume of how much you would need to take. And a lot of liquids have sorbitol in, which is sugar. And if you're taking a very sugary liquid, it's going to put you at risk of getting dumping syndrome. So what dumping syndrome is that as you take this liquid, you get very uncontrolled, quick. It moves from the stomach into the small intestine very quickly. And you get symptoms such as bloating, abdominal pain, diarrhea, vomiting. So to avoid that, we do try and think about the sugar content in the liquid formulations, and whether it may be better, rather than switching to a liquid formulation, to have tablets or opening up the capsules. But these are things that we consider and think about. And if the best thing for you is a liquid, then we will recommend you have liquid. If you're needing large volumes of liquid, one of the things to try and minimize this risk is to sip them slowly. So that considers a lot of your medications and the things that we need to start thinking about, because of that we will think about post-surgery. The other things that we need to think about is, after this surgery, will my body still be able to absorb nutrients? So quite often, you'll meet with the dietitian a couple of weeks afterwards, and you'll be started on quite a lot of supplements. Quite often the supplements that you'll be started on are calcium and vitamin D tablets, iron tablets, and multivitamins. So I'll just kind of go through the reason why and the rationale behind it. So with calcium, because of this decreased gastric acid, that's where some of your calcium is absorbed. So because you've not got as much of your acid, you're not going to be absorbing as much of your calcium. And there's a risk, again, with you not having as much absorbing calcium from your diet, you can have an increased risk of osteoporosis. So to, again, mitigate that risk, we advise that you take lifelong vitamin C and vitamin D tablets. Similarly, because of the decreased gastric acid and the fact that a lot of your iron is absorbed in the small intestine right next to the stomach, if you're bypassing that small intestine, you're going to be bypassing the site of iron absorption, one of the sites of iron absorption. So again, that combination puts you at risk of not absorbing as much iron from your diet because of the new anatomy. So again, we recommend taking lifelong iron tablets. And similarly with vitamin B12, because of the decreased gastric acid, you're not going to get as much absorbed, and the lack of intrinsic factor. So intrinsic factor is found only in the stomach. So when we reduced and cut, so obviously the result in the smaller stomach size, what happens is that you are removing the intrinsic factor, which is responsible for vitamin B12 absorption. So that's again why we need to make sure that you are on lifelong multivitamins to ensure that you're getting as much nutrients as you can. So you'll be started in the immediate post-op period, you'll be started a few different medication changes. So quite often patients are started on tinzaparin. So this is what we use at the Northern Care Alliance at Salford Royal. So the reason behind starting patients on tinzaparin, which is an example of a blood thinning injection, is that you're quite at risk of developing a post-op clot. So because you're not as mobile, because you've gone through surgery, which is again high risk, the combination of that puts you at risk of developing a blood clot. So the surgeons decide how long they want you to stay on it for, and what dose you take depends on your weight. So sometimes patients can be on it for 5 days, sometimes patients can be on it for 7 days, and surgeons will consider the patient's history if they're at risk of developing it, and maybe we've seen it as be extended at 28 days as well. So this is just in the post-op acute period. So it will be for 5 to 7 or 28 days after the operation, and that's it. Quite often we'll start you on something to help manage your pain. And the most common regime is to start patients on liquid paracetamol and codeine tablets. Now, this is obviously just if patients weren't on any medications to manage their pain before. The other medications that we normally start patients on to prevent ulcers forming at the site of surgery are lansoprazole. So lansoprazole, as I'm sure you're quite maybe not aware, but this reduces the gastric acid in the stomach, and it will prevent acid from forming at the site of surgery, and it will reduce your risk of developing an ulcer. So these are all the kind of stuff that you'd normally acutely be started on. After this, 2 to 4 weeks post-op, depending on how you tolerate and how much you're managing, then that's when we normally start you on all the vitamin and mineral supplements for life. Like I said, we'll normally review your medications on discharge. Some medications may stop temporarily and some may stop permanently. This is especially in the case of quite often diabetes medications.